So much, Stacy, for having me on. Hey guys, thanks for joining in virtually. I hope that everyone is doing well and staying safe during this really, really tough time. We had this on the schedule for me to give this presentation for a few months, so this is kind of pre-COVID-19, but given that idiopathic multicenter Castleman disease is a cytokine storm disorder, and there's a lot of clinical and pathological overlap with COVID-19, I thought that I would adjust my talk today to highlight some of the overlap between these two cytokine storm disorders. A couple of disclosures to share, research funding I receive, and also study drug. My three main objectives for today are to discuss the cytokine storm disorder idiopathic multicenter Castleman disease and what we can apply from what we know about iMCd to treating and caring for patients with COVID-19, to review treatment of iMCd, and also to highlight some novel insights and research that has recently emerged related to iMCd. So my plan for today is to start with a basic background of iMCd, talk about some potential insights into COVID-19, and then highlight some novel mechanisms and targets we've uncovered in iMCd, which could potentially be a blueprint for some steps that could be taken for COVID. And I just highlight in the bottom right of the screen, it's an image of a virus with a corona on top of it. And I have that on a number of slides, and basically any idiopathic MCD slide where there is something highly COVID or coronavirus relevant, I put a little coronavirus icon on the bottom right of the screen. So to start off with, well, what is Castleman disease? Castleman disease describes a group of 4 disorders that all share a common appearance under the microscope. So if you cut out a lymph node from any patient with Castleman disease, they'll look the same under the microscope. The bottom left of the screen is a photo of a germinal center, which is where your B cells go to mature within a lymph node. And then you can see a picture above is of Benjamin Castleman. So he's the pathologist who first described Castleman disease back in 1954. So the 4 types of Castleman disease, the first is unicentric Castleman disease, where there's a single region of enlarged lymph nodes. Those patients are generally cured with surgery. They often have few symptoms, and there are 3 forms of multicentric Castleman disease, which is really what is so similar to the cytokine storm that we see in COVID-19. There's a form of multicentric Castleman disease. It's caused by a virus, human herpes virus 8 or KSHV, where the virus initiates and ignites a cytokine storm, which leads to production of viral and also human interleukin 6. Thankfully, if you use the drug Siltuximab to deplete B cells, you'll actually halt the cytokine storm, which seems kind of counterintuitive that knocking out one of your immune cells is the right way to treat a viral infection gone out of control. But actually, if you deplete B cells, that's the home for the HHV virus, and you can stop the disease. The third type of Castleman disease is what's called POEMS-associated MCD. So POEMS is a paraneoplastic syndrome where you have a monoclonal plasma cell population. And in this case, that monoclonal plasma cell population actually produces the cytokines that cause the cytokine storm. And so one form of MCD is caused by a virus, HHV8, igniting the cytokine storm. Another form is caused by POEMS, where it's this cancer cell population that ignites the cytokine storm. And the third type of multicenter Castleman disease is what we call idiopathic multicenter Castleman disease. And that's where you get a similar cytokine storm, but there is no virus and there is no paraneoplastic cancer that is causing the cytokine storm. So we don't know what causes it, so we call it idiopathic. Very little is understood about it, but thankfully we do know that targeting one particular cytokine called interleukin 6 is actually quite effective in about 1/3 to 1/2 of patients. So my talk is going to focus primarily on what we call idiopathic multicenter Castleman disease. And just to give you guys a sense for incidence, there are somewhere around 5,000 to 7,000 new cases diagnosed each year of Castleman disease in the US, with idiopathic MCD accounting for about 1,000 to 1,500 of those new cases each year. And 1/3 of patients will die within 5 years, and another 1/3 will die within 10 years of diagnosis. Importantly, iMCD and each of these disorders can affect individuals of all ages. A little bit on the diagnostic criteria for iMCd. You need to have multiple regions of enlarged lymph nodes and multicentric lymphadenopathy. You need lymph nodes that demonstrate particular histopathological features that are consistent with Castleman disease, similar to what Benjamin Castleman described back in 1954. This is an example of a Castleman's lymph node, and you can see there's a small germinal center in the middle compared to a normal lymph node where it's much bigger germinal center with an expanded or widened mantle zone relative to the less expanded mantle zone in a normal lymph node. And then lots of blood vessels between germinal centers. And so these features are consistent with Castleman disease, but they're not black and white, and it's not always easy to say this is a Castleman's lymph node versus a lymphoma lymph node, for example. In addition to the pathological features, you also need to have at least 2 of these 11 clinical or laboratory features to make the diagnosis of iMCd. And also, you need to exclude diseases that can show, they can mimic or overlap with iMCd. And you can see here, iMCd really sits kind of at the intersection between autoimmune, malignant, and infectious diseases. And as you look at this Venn diagram, you see that there are a number of conditions that can ignite cytokine storms, like HLH. Here, of course, iMCd, you can get a cytokine storm looking picture with an acute EBV and HIV infection. And of course, now we know that's the case with COVID-19. A little bit about where we are with pathogenesis of iMCd. So for years, we were really focused on characterizing, well, what is it? What is the clinical and pathological picture of iMCd? And we have a pretty good grasp for those now, which are listed at the bottom of the screen. And then we wanted to know, well, what causes it? What is leading to the cytokine storm and this organ dysfunction? And we predicted it was some sort of soluble factor, and Kazuo Yoshizaki back in the late 80s performed a series of experiments where he found out that interleukin-6 was in fact elevated, and it was actually only 2 Castleman's patients. He published a paper describing it being elevated in a couple patients, and then he dedicated his life to identifying a drug that could block interleukin-6 so that he could potentially treat these patients, because he thought that this is the cytokine that was driving the disease. And a little bit later on, I'll go into some of the work that Kazu did. So we, for a while, believed that interleukin-6 causes or kind of drives all forms of iMCd. And interleukin-6 is a cytokine, it's a pro-inflammatory cytokine that your immune cells produce in response to an infection, in response to cancer. It's an important signaling molecule that all of us need. However, excess levels of interleukin-6 can cause a variety of issues. Even when we figured out interleukin-6 was important in iMCd, there was still this giant black box. Well, why is the interleukin-6 being produced in the first case for these patients who are HHV8 negative? What are the cell types, signaling pathways? What's the etiology behind what's leading this? And that all really has been a black box. But thankfully, on the shoulders of Kazu, there has been work done to develop antibodies against interleukin-6 directly and the receptor for interleukin-6. And thankfully, if you give the drug Siltuximab, which targets IL-6 directly, about 1/3 to 1/2 of iMCd patients will actually improve completely. They'll have this really incredible response to Siltuximab and get better. But unfortunately, for about 1/2 to 2/3 of patients, IL-6 blockade is not effective for ending and stopping the cytokine storm. So we don't know what is driving and mediating the cytokine storm in those patients. And for those patients, we need to give them either conventional or targeted chemotherapies, really not knowing what to target because we don't know what's leading to this cytokine storm. A little bit more about Siltuximab for the treatment of iMCd. Siltuximab, I mentioned, works in about 1/3, and I can say as much as 1/2 of patients based on some retrospective work that our group did. And it went on to get FDA approval for iMCd back in 2014. We did find that there were a number of laboratory and clinical abnormalities that were associated with a higher response to therapy. So that's why I say it's somewhere between 1/3 and 1/2 of patients that do respond to Siltuximab. And about a year ago, we published some laboratory tests that were, again, associated with likelihood of response. I put the little coronavirus in the bottom right of this page in this slide because there has already been one clinical trial of Siltuximab and others are on the way in the most severe COVID-19 patients. And unfortunately, they have not published the control group, but the group of patients who received Siltuximab had what seemed to be a promising response to IL-6 blockade. So why would IL-6 blockade not work in some iMCd patients? Well, work from our lab and others has found that some patients just don't have elevated IL-6. And we've also found in our lab that there are a number of other cytokines and chemokines that are also highly elevated, though we've always thought of Castleman disease as this IL-6 driven disorder, which it is for 1/3 to 1/2 of patients. Even in patients where IL-6 is the driver, meaning that if you block it, you can stop the cytokine storm, there are other cytokines and chemokines that are quite elevated. So I highlight a couple here. VEGF, vascular endothelial growth factor, is one of the most significantly elevated cytokines in the blood of iMCd patients. I showed in the bottom left of the screen, CXCL13 is another cytokine that we find to be highly elevated in iMCd patients. And I put the coronavirus in the bottom right because VEGF is also one of the most highly elevated cytokines in patients who have a COVID-19 cytokine storm. So a couple years ago, we pulled together data from a large number of patients to establish the first ever treatment guidelines for iMCd. And I'm not going to go into this in too much depth, but basically, regardless of whether you're severe or non-severe, we recommend IL-6 blockade frontline. And if patients don't respond to IL-6 blockade and they're quote unquote non-severe, which means they're really not in the ICU, but they're likely still hospitalized, those patients can get some targeted therapies like rituximabs or immunomodulators. But unfortunately, there's very little data on what's best to do for patients who fail IL-6 blockade. Patients who are most severe, we also recommend the IL-6 blockade, but we also recommend that if patients show any sign of deterioration while on IL-6 blockade, that chemotherapy is initiated right away. And so you may again think, well, that's strange to use chemotherapy in a patient who's in the ICU with a cytokine storm. Well, chemotherapy is actually very effective in iMCd patients that have cytokine storms, and they'll go from dying in the ICU to having what can often be a really quick turnaround with multi-agent chemotherapy. And the thought there is that we're depleting all of these immune cells that are wreaking such havoc. So I wanted to now transition into some potential insights into COVID-19 pathogenesis. So on the left column, you've got the Castleman cytokine storm, and on the right column, you've got the COVID-19 cytokine storm. And really, a couple of things I should highlight. The first off is that all patients have constitutional symptoms, so that's like flu-like, fevers, night sweats, that sort of stuff. What is becoming clear in Castleman's and also COVID-19 is that the most severe patients also demonstrate quite severe renal dysfunction and also cardiac dysfunction. Interestingly, about 1/3 of iMCd patients and about 1/3 of these really severe COVID-19 patients will have thrombocytopenia. The etiology is a bit unknown, but we believe it, in Castleman's, we believe it to be autoantibody-driven thrombocytopenia. Very elevated D-dimers in both groups, especially the most critically ill, very elevated C-reactive protein levels in both groups, again, especially the most critically ill. One thing that is different is lymphocyte counts. So in iMCD, we see patients that can have high, normal, or low lymphocyte counts. This is circulating lymphocyte counts, whereas in COVID, most patients are presenting with low lymphocyte counts in circulation. We don't know if that's because they're actually going into tissue and that they're actually similar numbers of lymphocytes, they're just all in your lungs, for example, or if it's that there's some reason that these lymphocytes are being depleted. And then, of course, as we mentioned earlier, interleukin-6 is quite elevated in iMCD and also in COVID-19. So I just wanted to highlight a framework that my group put together. This paper is currently in submission, but it's a framework to try to highlight what are some potential therapeutic targets in COVID-19 and what are the drugs that have already been used and a couple others that are in trials now against COVID-19 and where they fit into this. So SARS-CoV-2 infects individuals by binding to the ACE2 receptor, which we're learning there are ACE2 receptors on more and more cells we're learning about, it seems like every week, but primarily these bronchial epithelial cells. Once in the cell, the virus replicates. Then there has to be cell-to-cell transmission and what we call this RNA-emia, where you have very high viral loads in the serum. And then some patients will go on to have a normal immune response and have resolution, whereas a small fraction will have a weak or a suboptimal immune response, which will lead to increased viral replication. And if you continue to have a weak response, then you can get quite sick. But the hope is that if you have a weak immune response, that you can modulate that immune response and have the appropriate one. Unfortunately, some patients will have this hyperimmune response, what we're calling a cytokine storm, which can lead to ARDS and multi-system organ failure. So as we think about the drugs that have been tried thus far against COVID-19, and I'm only highlighting on this slide drugs that have already been given to humans with COVID-19, with an exception of 2 drugs that I added on to this slide. But other than that, every other drug. So each of these drugs has been given to humans with COVID-19 already. These drugs were given some intentionally based on this potential mechanism of action, others anecdotally. We know that we believe that these 5 drugs, based on in vitro data, are able to interfere with the ability for SARS-CoV-2 to get into bronchial epithelial cells. Again, we believe based on in vitro data, but certainly a lot of this is very preliminary. And then these next 7 compounds listed here are all believed to be able to interfere with viral replication. So these are antivirals that have, again, all been given to humans with COVID-19. And then these are 3 approaches that can block, once the virus is replicating in cells, this is really preventing cell-to-cell transmission of COVID-19. You can use convalescent plasma from from individuals who are healthy now, but they've already battled COVID-19 and have neutralizing antibodies, thimapentin, which can help to boost up antibody production, or is believed to, or you can give someone just IVIG, which is a bunch of non-specific antibodies, and hope that some of those antibodies will cross-react with SARS-CoV-2. Another approach you can do to try to prevent a weak immune response, which is basically to boost the immune response, is using a drug like interferon or thymosin alpha-1. These, again, have all been given to humans with COVID-19. And then corticosteroids, of course, can be used on the other side of things, that if you look like you're going towards a hyperimmune response, you could consider a corticosteroid to try to prevent that hyperimmune response. I also add on hydroxychloroquine and IVIG as potentially being able to have a similar sort of mechanism of action. And then lastly, if you do have a hyperimmune response and you're going towards ARDS, multi-system organ failure, then corticosteroids and tocilizumab were 2 of our first 115 drugs that we found. And then since then, siltuximab and cerulumab have been reported to be given to try to stop this hyperinflammatory response from turning into ARDS, multi-system organ failure, and death. So this is kind of how our group is thinking about COVID-19 and how each of the drugs that have been tried to date, whether they've been effective or not, these are the places in the pathway that they're trying to work towards. So this next slide, I want to highlight a couple of drugs in particular. So this is the IL-6 blocker this is a type of IL-6 blocker that I mentioned earlier, and that's tocilizumab. Tocilizumab blocks the IL-6 receptor. It was developed actually by Kazuo Yoshizaki, which I'll share a bit about later on. But tocilizumab blocks the receptor for IL-6, and based on the observation that IL-6 is quite elevated in COVID-19, a group in China decided to give tocilizumab to 21 patients. And when you look on the right side of the screen and you look at how CRP levels, temperatures, oxygen sats, the concentration of oxygen inhalation, how these all improved really dramatically right after giving tocilizumab, we all were really, really optimistic that maybe this drug is going to be really effective against the most severe COVID-19 patients. And you can see a little bit more about the study. So 19 out of 21 patients were discharged. 2 were still in the hospital at the time of publication. This is, I think, really promising and got a lot of us really interested in the idea of using IL-6 blockers against COVID-19. I mentioned Kazuo Yoshizaki early on. He was the person who found IL-6 to be elevated in iMCd. He actually went on to develop tocilizumab. So this drug, tocilizumab or Actemra, is a drug he developed in his lab. And before he transitioned to giving it to humans, I had heard that he gave it to himself. And Kazu's a good friend of mine, and I went to Kazu. I said, Kazu, Makoto told me that you gave tocilizumab to yourself as the first human to prove that it was safe. And he told me, he said, no, I didn't give it to myself. The nurse, she gave it to me. And I said, exactly, Kazu. So Kazu Yoshizaki, not only did he develop tocilizumab, but he also tested it on himself as the first human to ever receive tocilizumab. And it went on to get approval in Japan for multicenter Castleman disease. And then in the United States, the company never decided to get an approval for MCD, but it did get an approval for rheumatoid arthritis. So many of you guys will recognize this picture of Emily Whitehead about 10 years ago when she was one of the first pediatric patients at CHOP right next door to us to receive CART therapy, and she was experiencing a cytokine storm very similar to idiopathic multicenter Castleman disease. She was given tocilizumab, this drug that Kazu developed 25 years before for Castleman disease, and thankfully it saved Emily's life. More recently, tocilizumab, as I shared, based on the promising data from that first study in China, has received some attention based on patients that it's been given to off-label here in the U.S., and they call it a rheumatoid arthritis medication because that's what it's approved for in the U.S., but it was initially developed and approved for multicenter Castleman disease back in Japan. So yesterday, the first two randomized controlled trials came out of IL-6 blockers. The first is of sarilumab, which also targets the IL-6 receptor, just like tocilizumab, but they reported really disappointing results. So there was no benefit when you combine severe and critical patients. And there was a possible signal in the most critically ill. So if you have severe and critical, no statistically significant benefit. But if you look just at the most critically ill, it seems that there might be an improvement in the discharge rate and also in the proportion of patients who died or were on a ventilator compared to placebo. However, this is going to need to be studied in more patients. So critically ill patients will continue to be enrolled, but they will no longer enroll severe patients. And as you can see here, these are from news articles. So these papers have not undergone any sort of peer review, but these are data directly from the drug companies. What was a bit concerning about this result is that there were similar outcomes in patients to that previous TOSI study that I shared, but unfortunately, the control group also had similar outcomes too. So it may not be that the drug is actually causing this improvement. It may actually be that these patients were going to improve anyway. And then a couple minutes later, a study regarding tocilizumab reported that they achieved their primary endpoint. So sarilumab and tocilizumab both block the receptor for IL-6, and on the same day, within minutes, reported out different results. So the tocilizumab study also looked at these moderate to severe patients, and they did achieve their primary efficacy endpoint of having significantly fewer patients dead or on ventilators by day 14 compared to the control group. So obviously we're all going to be eager to see these results in peer-reviewed journals, but for now this is an interesting and kind of hard to piece together result, potentially different mechanisms of action that we're not aware of. So my research lab recently decided to pivot to try to contribute our experiences from cytokine storm disorders and drug repurposing towards COVID-19. We started what we call the Corona Project, and so that's COVID-19 Registry of off-label and new agents. Phase one of that project was reviewing through 2,700 articles. We assembled a team of 31 volunteers who read through the 2,700 articles, which took collectively about 1,000 hours of work between my lab members, PenMed students, and volunteers. We identified 155 studies that met inclusion criteria, which is that they reported the use of an off-label drug or an experimental agent given to humans with COVID-19. So this is a registry of humans who have received a drug, not in vitro data. And we found data on over 9,000 patients from 14 countries who received some drug with the intention of treating COVID-19, and we found a total of 115 different drugs were reported. You can see the class of those drugs in the top. You can see a listing of the most frequently administered drugs in the next figure below. And then you can see our attempt to try to get some information on some of the drugs that were most frequently used as far as the average time until a clinically meaningful response, which for us, that meant discharge from the hospital or complete symptom resolution. I just want to highlight a couple of members of my lab who really were instrumental in this. The first is Sheila Pearson in the bottom left of the screen. Sheila did all of the data wrangling. There was a lot of data that she was able to clean and analyze, and really dedicated weeks of her life towards this project. And also Johnson Core, who served as a project manager for this, helping to make sure and coordinate all of these people from PenMed and my lab and volunteers who were all involved in going through this really monumental project. And so where we are in phase 2 is that we've decided that we want to keep an up-to-date registry. So we are now in the process of going through the approximately 4,000 articles published since the first 2,700, with the goal of keeping this up-to-date registry of all treatments. You can find that registry at czn.org/repurpose. And please do contact me if you're interested in getting involved in any way, whether it's helping to enter in data or it's helping to think about how to interpret these results. So in the next about 15 or to 20 minutes or so, I'm going to talk a little bit about some novel mechanisms we've uncovered in iMCd, and with the idea that maybe these can provide some insights into COVID-19 as well. So just wanted to give a bit of a framework from my lab and how we think about everything we do against iMCd. We recognize that really the platform upon which all research needs to be done in rare disease really has to be based on a really strong foundation of a global network of physicians, researchers, and patients who have all signed on to sharing samples with one another, working together, promoting collaboration. That really has to be the foundation of rare disease research. And we have a foundation called the Castleman Disease Collaborative Network that helps to facilitate this really foundational element. And then on top of that, you need to use that community to really define what is the disease that you're talking about clinically and pathologically, in addition to getting everyone to work together. Let's get everyone to define the disease appropriately. And once we could do that, then we had a really strong base to work upon. And for us, the next step was really to procure high-quality patient samples with correlative clinical data. So we get samples from patients, and we also have extensive clinical data on all of these patients through what we call our Accelerate Natural History Registry. Next, we perform hypothesis-generating studies, omic studies that really are discovery-level kind of studies to give us hypotheses. And then we really dive deeply into our hypothesis-driven work into those mechanisms that we uncover from our discovery-level work. And then the kind of final piece of this puzzle is that we move our hypothesis-driven work forward towards identifying potentially novel therapeutics, and then we assess the efficacy of those novel approaches through our natural history study and also through clinical trials. And so this is kind of the framework within which we do work, and I think is an important path that can be considered for other rare diseases. I'm going to quickly highlight a case report that led us towards a novel therapeutic approach. This is a patient who presented with a clinical picture very similar to what we see, again, in COVID-19. Really acutely ill. Physical exam highlighted multicentric lymphadenopathy, fluid accumulation, some mild laboratory abnormalities, but notably fluid accumulation and splenomegaly. So the workup at this stage was lymphoma versus virus versus autoimmune condition, which is often the workup for iMCd. So there's a rapid clinical decline. Patient got extremely ill with multi-organ failure. This is the clinical picture. This is in the ICU at HUP, which is going to be a similar clinical picture to those of you that are taking care of COVID-19 ICU patients right now. So very sick, very quickly, with systemic inflammation really being the most notable finding, and really all the organ failure being secondary to that. So how did we treat this really sick patient? Well, we started out with high-dose corticosteroids. I should mention the vertical lines represent when the patient was admitted to the hospital each of the 5 times. And then you can see a number of laboratory tests and how they peak and drop with various therapies. But high-dose solumedrol was used, rituximab was used, siltuximab was used. But what eventually resulted in an extended remission was multi-agent chemotherapy with adriamycin, cytoxin, etoposide, Blockade, dexlutamide, a combo of chemotherapy agents that's often used in multiple myeloma. And that resulted in about a year-long remission. But the patient was kept on Siltuximab, which is this IL-6 blocker that targets IL-6 directly. And unfortunately, the patient relapsed on that drug and needed multi-agent chemotherapy again, which again gave about a year-long remission before another relapse. At this stage, the patient had failed to respond to IL-6 blockade. Chemotherapy wasn't able to keep the disease in remission. Drugs like cyclosporin that we were kind of shooting from the hip, trying anything we could, didn't seem to work. So what do you do when you've basically run out of options? And so in this case, every drug that had been tried against this disease had not worked, so we had to figure out a novel approach. We dove deeply into cytokine panels that we've been running on this patient, and you can see VEGF was one of the cytokines that began to rise in the weeks and months leading up to the 5th relapse. Same with soluble IL-2 receptor, which is a marker of T-cell activation. So this data suggested to us that there were activated T cells and there was elevated VEGF. Again, I have the coronavirus in the bottom right of the screen because these are 2 findings that have been very consistent in COVID-19. And then we have clinical features that are consistent with an important role of VEGF. And VEGF is important for vascular endothelial growth. And so we see increased vascular endothelial growth in lymph nodes and also on the skin. So these are some cherry hemangiomas described in the skin of this patient, and also capillary leak syndrome, which is what can happen when you have high VEGF. You gain lots of fluid all over the body. So based on the observation that there's increased T-cell activation, VEGF production, cytokine production, we really asked the question, is there something that could be unifying, a particular signaling pathway that could be critical to each of these features, a druggable target, most importantly, that could be critical to this? And so we ran proteomics data through our pathway analyses, 3 different pathway analyses tools, and PI3 kinase AKT mTOR was enriched across all 3 of the tools, so predicted to be important. And then we ran a really important experiment to look for mTOR activation in this patient's lymph node. So mTOR is critical for proliferation, in particular for T and B cell proliferation in the immune system, as well as for VEGF production. So we thought mTOR was a really interesting target, and so we did a stain for mTOR activation. This is a normal lymph node, so what we call a sentinel lymph node, a patient with breast cancer. We got a normal lymph node out, and you can see that there's some mTOR activation, which stains positive stains brown, and then we have a counter stain for nuclei that's blue. So blue is basically negative staining, brown is positive. And you can see in the sentinel lymph node there's some positive staining, but it's mostly negative. Then you can see this patient's lymph node, and you can see that it's really the inverse. It's a tremendous amount of mTOR activation all throughout the lymph node, but in particular in the interfollicular spaces, so between these follicles. And so basically our clinical and our cytokine data pointed us towards a potential role for mTOR. Our serum proteomics pathway analyses further pointed us towards mTOR, and then we now had kind of in black and white in front of us from this lymph node experiment that there was increased mTOR activation. Now, that doesn't mean that targeting mTOR with a drug is going to be effective. There are a lot of times where things are active and present, but they're not necessarily drivers. But nevertheless, we were really out of options, and so based on this, we decided to try the mTOR inhibitor sirolimus, which has been around for over 30 years. It is used in kidney transplant rejection to prevent rejection of organs through being a really potent mTOR inhibitor. And so for this patient, it's been 75.77 months, so the patient's been in remission. And this patient is me. I was diagnosed with Castleman disease when I was a medical student, and now it's been over 75 months since my last relapse. The New York Times called it a doctor cure thyself a couple years ago, which I think is a bit of an overstatement, but it did allow my wife and I to make it to our wedding day. This is us on our wedding day about 73 or 72 months ago. And my hair grew back just in time, which was actually pretty important to me. These are just a couple pictures of me throughout my journey getting chemo and really nearly dying 5 times. So a question that I imagine many of you guys are asking is, well, if mTOR is up in you, is mTOR also increased in other patients? So my lab's been focused on that, and we've got a paper that will be coming out soon in Blood, where we looked at mTOR activation across a number of other MCD patients, and we found that no matter what readout we used, we kept finding increased mTOR activation in lymph node tissue from iMCD patients. We looked at a total of 26 different iMCD patients. And then another question that you might ask is, well, maybe mTOR is up in your lymph nodes, but maybe it's just up in every disease where there are big lymph nodes. This is work that was led by Daniel Arenas, who's pictured here, and also Dustin Schilling before him, who helped to lead our lab. And what we found was that, yes, there's increased mTOR activation in iMCD where there are big lymph nodes, but it's actually significantly increased mTOR activation relative to other diseases where there are enlarged lymph nodes, like reactive lymph nodes, Hodgkin lymphoma, and lupus. So it's got a similar level of mTOR activation to a disease called ALPS, autoimmune lymphoproliferative syndrome, which many of you guys may be aware of, especially on the CHOP side. ALPS presents in children and is actually treated with an mTOR inhibitor, sirolimus, first line. It's work that Dave Tichy led from CHOP, and so it's mTOR activation increased compared to enlarged lymph nodes to a similar level as what we see in ALPS. And these are some additional images of these lymph nodes. And then we started to look to see, well, what are the cell types with increased mTOR activation? We've thus far only looked at 4 cases, and there's really not a clear picture. There are a number of different cell types that seem to be co-staining between mTOR and these cell-specific markers. I've got some white arrows to highlight those cells where it looks like they're double-stained, but we still have more work to do. It looks like plasma cells and maybe macrophages are 2 of the more to make it most of the mTOR positive cells, but actually there's still a large portion of mTOR positive cells that we don't know what cell type they are. And we also use an orthogonal platform. We use our proteomics data to also see whether there'd be enrichment of the mTOR pathway, and we did find, in fact, that there was. An incredible PhD student in my lab, Ruth Ann Langen, has done some really important work with phosphoflow to stimulate cells from iMCD patients. So here in red, we stimulate immune cells with interleukin-6, and we find that actually there's increased mTOR activation as you stimulate, as time goes on, following stimulation of these iMCD cells relative to healthy donors. And then we decided to use the JAK inhibitor ruxolitinib. We were able to show that in CD4s and CD8 T cells that there's a significant decline in mTOR activation when you block JAK1, JAK2 with ruxolitinib. So IL-6 driven mTOR activation that is JAK1/2 mediated is something that this is the first functional data that we've ever discovered, and as I mentioned, will be published shortly. So when we think about kind of how this fits together, we know that mTOR is activated in iMCD lymph node tissue. We know there are multiple cell types that demonstrate the activation. Pharmacologic mTOR inhibition can induce a durable clinical response, and monocytes and T cells, when you stimulate with IL-6 blockade, or IL-6, you can induce increased mTOR activation. And we think that JAK could potentially be an important mediator. A few months ago, we published our work on the first 3 patients ever treated with an mTOR inhibitor. So I was one of those patients. And then about 6 months ago, we opened up the first clinical trial of sirolimus and anti-IL-6 refractory iMCD patients, which is technically open, although we have not been enrolling patients due to COVID-19. So in the next 10 minutes or so, I want to highlight another story from my lab that really is hopefully a model for some of the things that could be done in COVID-19. As we think about COVID and Castleman's, these are 2 very heterogeneous diseases. So you've got some patients that are asymptomatic. You've got some patients who are dying in the ICU. same sort of thing that we see in iMCd. And this is just one of your standard precision medicine slides where the old approach is you've got 5 patients that are different. You give them the same drug, and some people respond, some people don't respond. The paradigm that we are all working towards is you've got the same different patients like we did before, but now we've got a series of tests that we can do to help to predict who is likely to respond to drug A versus drug B versus drug C. And so in order to do this, you need to both identify effective biomarkers, and you also need to identify effective therapies. And that's where we are with COVID-19, and we need to be able to precisely separate patients into different groups, and then make sure we have multiple therapies available depending on what group we put those patients in. So this is something that we've been doing for quite some time in Castleman's, and I thought I would share at least one of those stories. I don't think I'll have time to share the second story. So the first one is that we spent a couple years, maybe as many as 3 years, working to assemble serum samples from a very large cohort of patients. And I've got Sheila photographed again because she did such a great job leading this project. But basically, we wanted to get samples from a bunch of iMCd patients and also from some related disease control samples. And we measured 1,300 serum analytes in those samples. And so the idea being, the first question was, well, let's see how similar iMCd is to some related diseases. Is it more like a lymphoma? So is it more cancer-like? Is it more like an infection like HHV8? Is it more like an autoimmune disease like rheumatoid arthritis? And so this first plot is a t-SNE plot. And so t-SNE plots, the location of every point is relative to the other points. So each point here on this plot represents a single sample, so a single patient. And the closer the 2 dots are to one another, the more similar those samples are across 1,300 analytes. It's a way to reduce 1,300 dimensions down to a 2-dimensional plot. And you can see that these lymphoma samples clustered quite closely together. So the lymphoma serum samples are very similar to one another. The HHV8 positive MCD, HIV positive samples are also very similar together. They cluster together quite well. And the rheumatoid arthritis samples also cluster together quite well. And interestingly, the RA and the HIV samples happen to cluster very closely. The next question we had is, well, where is iMCd going to cluster? And can this give us some insights into, is iMCd more like an autoimmune disease or an infectious disease or a cancer? And then our iMCd samples really kind of spanned the gamut all the way from samples that are very RA-like through samples that are very lymphoma-like. The next question, once we realized how heterogeneous it is well, maybe are there clusters within iMCd that can give us some insights into likely response to therapy? And we did find that, in fact, there was a large group, what we call cluster 1, that responded at a significantly higher rate than the non-cluster 1 samples. So whereas across everyone, about 1/3 of patients responded, if you just looked within cluster 1, about 2/3 of those patients responded to IL-6 blockade. We were then able to identify 7 proteins from within the 1,300 we measured that were particularly good at separating cluster 1 cases versus non-cluster 1. And then we looked in a separate validation cohort photographed on the bottom or on the right side of the screen, where we looked at an additional group of about 25 iMCd patients, and we were able to validate that, in fact, cluster 1 score using these 7 biomarkers was associated with response to IL-6 blockade. Now we have that kind of first level, which is a set of 7 proteins that can distinguish whether you're likely to respond versus not likely to respond. And the next question we said, well, what if, for the people who are not likely to respond, let's see if we can find additional drug targets for them. And so we did pathway analyses, like I mentioned earlier, and we found IL-6 JAK-STAT signaling was enriched in our responders, which was good because we expected that to be enriched in our IL-6 blockade responders, and that made us feel comfortable moving on to non-responders. And we were surprised when we looked at non-responders to find that IL-6 JAK-STAT3 signaling was also enriched in people who did not respond to IL-6 blockade. And so that made us wonder, could JAK-STAT3 be active in non-responders, and maybe it's a different ligand that's actually stimulating the IL-6 signaling. And so we've gone on to do immunohistochemistry and confirm that there is increased STAT3 activation in iMCD lymph nodes compared to controls. and there's no difference between responders and non-responders, suggesting that maybe there's just some other ligand other than IL-6 that's causing the increased STAT3 or JAK-STAT3 signaling in iMCd. So based on this, we're interested in using this JAK inhibitor to say, well, maybe you don't block IL-6, maybe you block JAK, and that will stop signaling. This slide, I think, is a nice summary slide, and then I think I'll skip forward to ask questions or to open it up for questions. But this summary slide highlights that we showed that mTOR is activated in iMCD lymph nodes across multiple cell types. We've shown that mTOR inhibition can induce responses in some iMCD patients, certainly not all. We highlighted that IL-6 JAK-STAT3 is enriched in proteomics data, and in tissue we've shown that STAT3 is activated. We've shown that IL-6 therapy, anti-IL-6 therapy, can induce responses also in some patients, and more recently that JAK may be a kind of central node that's important to both mTOR activation and also IL-6 signaling, and potentially to other cytokines that we haven't yet identified. So I had really ambitiously wanted to get through some of Ruth Ann's really important work that she did with phosphoflow. I don't think I have time to go through these slides now, but the bottom line is that Ruth Ann did single-cell RNA sequencing and flow cytometry, which identified increased T-cell activation in iMCD patient peripheral blood cells, again, similar to what we see in COVID. We also found some changes and some shifts in expression of various markers, like CD16 expression was decreased in flare samples, which again is something that has been reported, not yet published, but reported to occur in COVID-19. She also found a couple cell types had increased mTOR activation, and then she showed that there's increased interferon alpha response gene set in some patients. So maybe interferon alpha would be important in those patients where mTOR and IL-6 blockade is not effective. And then she showed, using a similar phosphoflow experiment, that stimulating iMCD samples with type 1 interferon could again increase mTOR activation. And again, she could use a JAK inhibitor, ruxolitinib, to abrogate the increased mTOR activation. So the addition of her work, which I know I went through very quickly, which will soon be published in JCI Insight, is that type 1 interferon may be a third way that we get to increase JAK-STAT signaling in iMCD, but more work is needed. So my last couple of slides are just highlighting, I love to show this cartoon. I have this brand new idea, and it's someone showing a wheel to someone else. I think oftentimes in research we can reinvent the wheel, and so my lab's tried really hard to document and share the various things that we've done against Castleman disease, so that other groups can try to not have to reinvent the wheel. So our plan moving forward is to continue to advance drug discovery for Castleman disease through both the Castleman Disease Collaborative Network and also the Center for Study and Treatment of Lymphadenopathies and Cytokine Storms, what we call the Castle, here at Penn, a center that I run. We know that about a third of the Castleman is taken care of, maybe as much as a half, but we've still got work to do. Well, I'm going to continue to collaborate with researchers from related inflammatory diseases like COVID and others, and continue to push forward the concept of drug repurposing and using drugs that are already FDA approved for one condition in other ways. And so here are a few ways that you guys as physicians and health professionals can contribute. So it's joining our physician researcher network, encouraging your patients with Castleman disease to enroll, notifying me if you come across Castleman's patients, and considering open positions in our center. So just a few key takeaways that I want to highlight. This is a very heterogeneous disease like COVID. We've fortunately been able to make some progress, but there's still a lot of work that can be done. I think that the idea of using drugs off-label is an important lesson for COVID-19, and I just wanted to highlight a couple, I guess, kind of key takeaways beyond the science of COVID-19, and some of these come from my book, Chasing My Cure, that came out last fall. And just three that I want to highlight. One is this concept of being in overtime. I think COVID-19 has made us realize that the clock is ticking for all of us, and that our health is the most important thing, and that it can be taken from us at any time, which should make us live, really with a sense of urgency. Another is to turn hope into action. That those of us on the call that are working the healthcare profession, we are often trying to turn other people's hope into action. People are hoping for progress, and we are doing what we can to turn that into action. And the last piece is that it really takes an army. I only showed a few photos on the screen. There are many, many more people, some of which are listed here, that have been really critical to our progress. So we have 9 minutes for questions, and I really would be delighted to answer any questions that you guys may have. Let's see. So it looks like there are 2 questions written into the chat. So the first one is, can I comment on detection of early markers of cytokine storm? So there was a physician in California who recently said that he identified a panel of lab tests that could help to predict who's likely to go into a cytokine storm. And unfortunately, those lab tests are not available anywhere. He initially shared them, but they're not shared online. So I don't know if that's because maybe they were not as reliable as he initially thought they would be. But I do think CRP, very high CRP on presentation from the data we've seen, does seem to suggest that someone is about to go into a cytokine storm. Of course, everyone who gets a viral infection will have elevated CRP, so we're not talking about 2 times the upper limits of normal, we're talking about 20 times the upper limits of normal. Those are the patients that you need to be really worried about. I think albumin is another one that I like to track, and that's because albumin is kind of a secondary marker. So when you have lots of inflammation, you start seeing a drop in albumin, but it really does require sufficient inflammation to see the albumin start to drop. So I like to use albumin as one of the acute phase reactants that I follow in our Castleman's patients. But I think it's going to be really important to do some of the similar things that we've done with serum proteomics and Castleman's to also have those done in COVID. The next question is a really good one. What's known about the genetics of MCD? So very, very little. Just in the last couple of years, the first couple single case reports have been published of a couple somatic mutations, one in a gene called MAP2K2 within lymph node tissue of an iMCd patient, and then another with DNMT3A in lymph node tissue. So potential somatic mutations that could be important. And then also potentially some germline mutations. So fast ligand mutations that are typically associated with ALPS were reported in a possible Castleman's patient. My lab is working on studying a gene called cabin1 and the role that cabin1 may be playing in hyperinflammation. But really the problem that we have is that we've been a bit behind on doing genetic sequencing, and we actually right now are in the middle of a project our goal is to get between 200 and 300 blood samples from iMCd patients so that we can do whole exome sequencing on a large cohort of patients. Great question. All right, so 3 more questions are typed in, and please feel free to add in additional questions if you're interested. So Jen asked, is there any indication of epigenetic alterations? So as of right now, there's been no research into the epigenetics of iMCD. What we see with patients relapsing and remitting and relapsing and remitting suggests to some of us that maybe there are some epigenetic changes that are making or maybe making patients susceptible when they encounter maybe the same environmental factor. So it's possible, but unfortunately, very little work has been done. Really, no work has been done. The next question is from Dan. To follow up on Jill's question about germline variants, is there any evidence for somatic mutations playing a role in iMCD? So yes, now there have been these 2 patients, a MAP2K2 mutation and a DNMT3A mutation. The challenge with the DNMT3A mutation is that gene is the most frequently somatically mutated gene in the genome. And of course, it's often found in CHIP. So the presence of a somatic DNMT3A mutation, it's hard to know what that really means, and there really was not sufficient functional follow-up work done. We've actually partnered with and actually funded a couple labs to do the functional work, and the results are still not out. And that's DNMT3A. As far as MAP2K2, there was some really good work done at MSK to demonstrate that this particular variant resulted in a survival advantage when we modeled it in another cell line. That paper was published in Oncogenes a couple months ago. But the challenge in a rare disease like Castleman's that's so heterogeneous, when you hear about an N=1 of a finding, you don't know if that patient truly has iMCD or maybe they have something else that was called iMCD, which is really, really challenging. Great. The next question is, Oh, yes. Are there any genes associated with Castleman's or other risk factors for cytokine storms? Uh, I think the best disease to point you to is HLH, hemophagocytic lymphohistiocytosis, where there are really well characterized mutations in genes that are important, like perforin, in basically eliminating activated CD8 T cells. And so you can imagine that if you have a mutation in a gene that eliminates your highly activated cells, then you'll have a hard time shutting down a hyperinflammatory response. And so I think that's an interesting area to look into, is these so-called breaks in the immune system, or at least death pathways for immune cells. But I think that more work needs to be done. I suspect that with COVID-19 causing such an intense cytokine storm, that I suspect there will be significant interest and a lot more work done in HLH, in Castleman disease, in CRS secondary to CAR therapy. Thankfully, Penn has been such a leader in studying CRS and CAR therapy, but I do think that there'll be increased interest in these sort of things. Let's see. Please see rapamycin question entered in chat section. Go over and see. I actually don't see a rapamycin question entered. Marnie, if you don't mind, please do send
David,
it along.
David, I can read it to you.
Oh, sure.
You may be still looking at the presenter part, but it just said, great presentation. Rapamycin effect is impressive. What doses are used? Is there a break given periodically off therapy? And is there concern about increased infection risk if on high-dose therapy in Castleman patients? Also, does it work in non-idiopathic forms of Castleman syndrome? And do other mTOR inhibitors besides sirolimus show in vitro evidence of efficacy?
Awesome question. So first answer is that we use the same dosing that was used by Dave Tichy in ALPS. So we just followed his standard dosing, which is actually the standard dosing used for a renal transplant. So 5 picograms per mil, 5 to 15 is the trough level that we look for. And so that could be anywhere from 1 milligram a day of taking the pill to taking as many as maybe 7 or 8 milligrams to reach that sort of a trough. Really, it's patient dependent. So that's the dose. We found in our first, we're aware of about 20 patients that have been given the drug off label. We just started enrolling patients into the trial, but off label, we've seen the drug anecdotally has worked, I'd say, in about 1/3 of those patients. And it's worked in the patients who were in the midst of an early flare to calm down and quiet their storm. It has not worked in the patients who have been in the ICU with multi-organ failure. So it actually, and this is anecdotally, it's a small number, we need the trial to enroll sufficient patients, but anecdotally it doesn't seem to have the ability, and maybe it's just the dosing that we're able to get to really squash a storm. It can prevent a storm on the uptick, but it can't stop a storm in its tracks in our experience. And from the literature, the rapamycin doses that have been needed to stop cytokine storms in mice have been like 20 to 100 times the sort of doses that we are able to get into humans, or at least trough levels that we get into humans. And so I think that those, to your question, I think there's some dose limiting toxicity to really being able to stop a cytokine storm. And in the setting of COVID-19, I've been thinking a lot about this question, does it make sense to use a drug like rapamycin in the early stage before the cytokine storm is about to hit? But the challenge is that you don't want to suppress someone that's fighting a virus, and you also don't want to use a drug that's unlikely to really halt a cytokine storm. So I think more work is going to be needed. Great. Well, thank you guys so much for these wonderful questions, and thanks so much for listening in today. And please, everyone, stay safe, and thank you for all you guys are doing in the COVID fight.